So I've been asked specifically to talk about men, and I'm aware many people in this room are probably delivering men, involved with men, so I'm going to try and give quite a broad overview of some of the work we're doing. There are a couple of some new data and facts which I'll share with you today, which some of you might not be aware of. So I'm probably speaking to the converted, but children in the UK have one of the highest prevalences of child obesity in the world. And that actually equates to 3 million, or a third of all children in the UK who are actually overweight or obese. We also know that the majority of obese children will go on to become obese adults. And obviously in times of recession and the new coalition government, cost is being scrutinised, and the cost of treating obese children accounts for 2 to 7% of total healthcare costs. And the predictions are that obesity is going to cost the NHS 50 billion by 2050. And we saw some figures by Phil earlier showing what the cost will be in the near future. So really, someone must do something about it. So meet MEND. MEND stands for Mind, Exercise, Nutrition, Do It. We've heard quite a lot today about physical activity, BMI, a bit on nutrition, but actually what we look to do is really incorporate and blend all those elements together. So mind, the behavior change, physical activity, nutrition, and Do It, I think, is a component that has been overlooked for some time in these types of interventions. This is really about empowering and motivating children and adults to make the changes for themselves. As practitioners, clinicians in this room, I'm sure you'll all agree you can tell people to stop drinking, to do more exercise, to eat a healthier diet, but until they actually decide to do it for themselves, you don't see any long-term change. So this is a key element of the work we do. So we create programs that help everyone change their lifestyle and tackle obesity. And we have a range of programs. Starting on the left, this is a brand new program that's being piloted in the east of England, Portsmouth, and Wales. And it's a targeted postnatal weight management program called Men Mums. Obviously, all the branding's in pink as well. On this side, we're now working with adults. We launched a national healthy lifestyle program called the More Active Health Program this year, and it's the only Department of Health approved program for adults under the Change for Life branding. And then we have our family programs, the ones in the middle here. So they're all family-based for children all the way from 2 up to 13. These two are specifically for overweight and obese kids, and the 2 to 4 program is for all kids, irrespective of their weight, so more focused on prevention and more of the treatment, on the treatment side. So all of our programs include healthy behavior change, really looking at teaching parents and children to start to implement very gradual changes in their lifestyle that over time will actually lead to substantial kind of health improvements. All the programs are obviously fun, working with kids. If it's not fun, they don't come, they don't enjoy it. So looking at making physical activity fun. Using nutrition education, and I can say this as a dietitian, you know, healthy eating can be damn boring. But, you know, we really look at making it practical. And, for example, one of the things we do is we show families that in a 500 milliliter bottle of Coca-Cola, there are 11 teaspoons of sugar. So we're not saying don't drink Coca-Cola. We're just saying, did you know that there are 11 teaspoons of sugar? Would you have a cup of tea with 11 teaspoons of sugar? So it's raising awareness. It's taking families to the supermarket. It's showing them how to cook, and obviously doing it all together. So children and parents doing it together. So the programs vary, and this just gives you an idea of the duration of them. So they vary from 6 to 10 weeks, either weekly or twice weekly, or a much more flexible approach for the adults program, the number of sessions, the duration, and the kind of team that's involved in delivering it. So a whole range of different structures and formats depending on the age of the children, and obviously different when working with adults. In today's climate, it's very important that programs are evidence-based and that we have the outcomes to show that what we're doing is effective in terms of health outcomes, but also equally important, cost-effective. And we work with leading academic institutions around the world who we do research with, so Great Ormond Street and UCL Institute of Child Health here in London, Baylor College of Medicine and University of Texas in Texas, and National Children's Medical Center in Washington, D.C., and Deakin in Australia. And what we've managed to do is we've built up an evidence base right from 2002, where we did our first feasibility trial, followed by a pilot, a first UK randomized controlled trial. We then evaluated the program in the real world, and I'll share some of that data with you. We are currently conducting a second UK RCT. We have an Australian RCT which started this year and a US RCT starting next year. And so what this has led to is really the largest evidence base on a community child weight management program of its kind worldwide. We're not aware of anything that has more data and more evidence behind it. The program for 7 to 13-year-olds is the only UK community-based weight management program with a completed successful randomized controlled trial. And just to acknowledge some of our international collaborators, some of you may be familiar with some of our collaborators here in the UK, Tim Cole, Alan Lucas, and Atul Singhal. In the US, we're working with people like Sarah Barlow. She actually authored the American Academy of Pediatrics paper on the treatment of child obesity, as well as Eric Finkelstein, who actually calculated the total cost of obesity in the US for President Obama, and Boyd Swinburne in Australia, who's the child obesity prevention guru, really, and Diane Finegood in Canada. So what our programs achieve? Well, we achieve major reductions in some of the unhealthy outcomes, things like obesity, central adiposity, psychological difficulties, sedentary behaviors, and risk factors for diabetes and cardiovascular disease. And we see improvements in things like healthy weight, blood pressure, self-esteem, fitness, and diet. So our randomized controlled trial really showed that at the end of the program, which is a 3-month point, all of our outcomes were reduced. So the kids lost weight, their waist circumference was reduced, they were more active, their self-esteem went up. But what was really interesting is that even after the 10-week program finished, we still continued to see these improvements in all of the outcomes. So even after the program finished, the outcomes continued to improve. Just to give you a sense of the scale, the difference between groups at 6 months was 4.3 centimeters. So that's like 2 notches on your belt, which is quite a substantial weight loss or waist circumference loss for kids. And for BMI, it was 2 BMI unit difference between groups. What was also really positive is the fact that we saw that all of our outcomes were sustained at 12 months. And what makes this really exciting from an academic perspective, but also I think from an implementation and delivery perspective, is that we now have very strong data showing that MEN not only works in a clinical trial, but also works in the real world. And when I say real world, I'm talking about all of you, all the people out there actually delivering MEN programs. Everyone who delivers our programs measures children at beginning and end of the program, 6, 12, and as long into the future as they can. And in fact, 71% of PCTs in England are now running one of our programs, one or more of our programs. And what this has enabled us to do is to evaluate this large-scale public health intervention in local communities, delivered by local staff, and to actually see what kind of effects are achieved. So this is data based on just over 6,500 children who've been through one of our 10-week programs. And you can see this is comparing our feasibility study to the randomized controlled trial, to the rollout data, that in terms of BMI, we're achieving very similar reductions in BMI across all 3 studies. When we look at waist circumference, it's actually really interesting because the community programs actually are achieving greater reductions in waist circumference than the feasibility study. And this study was run, this program was run by a specialist, a clinical psychologist, a pediatric dietitian, and a physiotherapist. So it's interesting that people working in communities that can actually achieve greater reductions and very similar to the randomized controlled trial. When we look at some of the actual outcomes, we see that kids are doing on average 4 hours more physical activity per week by the end of the program. They are spending on average 6 hours less time in front of computers and TV, so screen time, sedentary behaviors. We measure fitness using a validated step test, and you can see that the children are significantly fitter at the end of the program. And also very interestingly, we use the Strength and Difficulties Questionnaire, which is a measure of psychological symptoms in children, and we see reductions in psychological symptoms. We also see improvements in body esteem as well as self-esteem.